Hello everyone. Today we will discuss about biologic response of pulp to restorative materials and operative procedures. Pulp is a specialized connective tissue, we all know, and it is very sensitive to external stimuli. In addition to dental procedures that threaten the integrity of the pulp, injury may also result from the irritation by a noxious agent brought into contact with the exposed dentin or the pulp tissue. So in this video, we will discuss about all the factors that affect the integrity of the pulp. So let's first discuss about pulp-dentin organ, which is often referred to as pulp-dentin complex. So why it is called so? The pulp and dentin are anatomically and functionally integrated. Thus, they are referred as pulp-dentin complex. They are derived from dental papilla, whose cells migrate to the first branchial arc from within the ectomesenchyme of the cranial crest. And these tissues remain closely associated during the developmental phase. Now, what is the significance of this topic? Why are we discussing this? So, since there are so many products in the market, and the new ones are continuously being introduced. Now the question arises, which one to use and which is not safe for us. So before that, let's pledge to cause minimal added irritation to the pulp so as not to interfere with the normal pulp healing. Now we will discuss about the factors that affect the pulp reaction to restorative procedures. Under this, the first factor is the degree of inflammation of the pulp preoperatively. We all know that the pulp is compromised in its ability to respond to external irritants because it is enclosed in a non-compliant environment. What do you mean by the non-compliant environment? As we have discussed that dental pulp is a connective tissue which is uniquely situated within a rigid encasement of a mineralized dentin. And this rigid encasement provides the low compliance environment. So in this case, the nutrition for the tissue is almost entirely supplied via the vessels traversing the narrow apical foramen. So in recognition of this this concept, whenever there is any trauma to the pulp, there may be increase in the tissue pressure that will cause vasodilation resulting into plasma exudation, blood vessel compression which will lead to ischemia and thus causing the pulp necrosis. Apart from this, it also lacks sufficient collateral circulation. As we know that the pulp arterioles are the end arteries and thus they do not have any sufficient collateral circulation. So our aim should be to cause minimal added irritation to the pulp so as to save its function. Next is the amount of physical irritation caused by the procedures. Under this we have the first factor, that is the heat. Restorative procedures like cavity preparation, crown preparation or curing of resin during direct fabrication of the provisional restoration generates the heat. And this heat production has a detrimental effect to the health of the pulp. So what are the factors that governs the heat? Under this we have the three factors: the rotation per minute, the pressure and the surface area of the contact. By increasing the RPM, or the more the RPM, there will be more heat generated, and the more the pressure, the more the heat generation. And the third factor, the surface area of the contact, which is related to the size and shape of the revolving tool. The more the contact of the tooth structure and the revolving tool, the more the heat generated. This heat is detrimental for the function of the for the function and integrity of the pulp tissue because the permanent damage of the pulp can occur if it is heated beyond 130 degrees Fahrenheit. Even a temperature of 113 degrees Fahrenheit within the pulp can produce inflammatory response that could result in pulpitis or eventually pulp necrosis. Since the pressure is related to applied force, a reduction of this force is and using the coolant is advised to minimize the heat production. At least we can reduce the amount of heat generated so as to prevent any further added injury to the pulpal tissue. Next factor is desiccation. During cavity and crown preparation, it has been long known to cause aspiration of the odontoblastic nuclei into the dentinal tubules, and there may be significant displacement of the odontoblastic nuclei, which may eventually lead to pulpal inflammation. Even a study has shown that as little as 30 seconds of continuously air drying can cause the uninflamed pulp a significant displacement of the odontoblastic nuclei. And even the area of pulpal necrosis can be was related to the area that were dried. Coming on to the next factor, that is a biologic and chemical irritation. The residual cavity contamination prompted some researchers to use the cavity disinfectants. They started using certain caustic chemicals like hydrogen peroxide, sodium hypochlorite or calcium hydroxide solution. But in the contemporary practice, most of the chemical irritation occur because of the application of the etching agent, especially the total etch method, where we don't have any smear layer left to occlude the exposed dentinal tubule. So in that case, if the cavity is very much deep, the micro leakage can occur up to the pulpal tissue. Next factor is the unpolymerized monomer and higher concentration of the monomeric resin component. These unpolymerized monomeric component were shown to exert inhibitory effect on the T lymphocytes and spleens and macrophages and monocytes, and also these materials can directly leach into dentin and they can cause irritation to the pulpal tissue. And last factor is the polymerization shrinkage, which is inherent in the composite resin, and this may lead to further lead to secondary caries, and that can result into post-operative sensitivity. Next factor is pulp reaction to cavity remaining dentin thickness. So the cavity remaining dentin thickness dictates upon the two factors, that is odontoblast survival and the reactionary dentin secretion. These two important factors is governed by the remaining dentin thickness. So basically, a reactionary response is associated with a small and slowly progressive lesion, whereas in case of very active lesion, there will be obviously a death of the primary odontoblast, and in that case reparative dentogenesis will be seen. So basically, it is the activity of the caries lesion that have a strong influence on the nature of the tertiary dentinogenesis response. And next, the concentration and the amount of the chemical diffusing through the dentin to the pulp also depends upon the thickness of the leftover dentin. Coming on to permeability of the dentin, we all know that dentin is not uniformly permeable. The thickness of the dentinal tubules and the density of the dentinal tubules vary in the different areas of the dentin. In the DEJ, the number is less, whereas as we move on to the pulp, the number increases. And the location within the same tooth, and the age of the patient, and presence of the pathologic conditions. So what are the factors affecting the permeability of the dentin? The first factor is location. So under location, as we have discussed, dentin permeability varies in different areas of the same tooth. For example, it is increased toward the pulp side. This is because both the tubule diameter and the number increases toward the pulp chamber. The next factor is the concentration and solubility of the diffusing solute. The rate of diffusion is dependent on the applied concentration, but it is inversely proportional to the dentin thickness. And the surface area available for diffusion, the temperature and the chemical characteristics of the diffusing molecules also affect the diffusion. And the third factor is the intratubular material. Mineral deposits, like in case of sclerotic dentin or the tertiary dentin formation, where we have the collagen fibrils, and these deposits reduces the permeability of the dentin. And the next factor is the patency of the dentinal tubules. Sclerotic dentin is less permeable than the physiologic dentinal tubules. And the next factor is the reparative dentin. In cases wherever we have reparative dentin formed previously, the response of the pulp is less. Probably this is so because it reduces the penetration of the solute toward the pulp. The last but not the least is the remaining dentin thickness. As the length of the tubule increases, the concentration of the solute reaching the pulp decreases. So effective remaining dentin thickness of 2 mm, it is surprising that it provides an insulating barrier against almost all the technique and restorative materials. And even it has been shown that 0.5 mm thickness of dentin reduces the toxicity level of the material to 75% and 1 mm thickness to about 90%. So this is the significance of the remaining dentin thickness. Next factor is the patient age. Age may be associated with reduction in pulpal neuropeptides. In the younger one, we have a favorable results, or the more host factors they have the increased expression of the biological factors that is related to cell differentiation, proliferation and immune response, whereas in older pulp all of these factors are decreased and they are more of a related to the apoptosis. Now what are the reaction patterns that we can see in case of slight, strong and pulpal exposure case? So in case of slight irritation, the cavity preparation, say for example in medium cavity, which is filled with restorative material of low toxicity or diffusibility or due to the high hydrophobicity, and also there is no bacteria present. So in that case, if there is no further added irritation, so there will be reactionary, new reactionary dentin formation and the result will be favorable. But in case the irritation persists or we have a strong persistent irritation, that will eventually lead to more extended pulpal inflammation. Say for example, in case of bacteria at the cavity floor beneath the restorative material, in that case inflammation is not going to resolve by itself and potentially it will lead to pulp necrosis over a period of time. And the third reaction pattern is the pulp exposure. It is associated with the loss of the primary odontoblast, and the new odontoblast cannot regenerate from the neighboring odontoblast by the cell division. So here we don't have any primary odontoblast left out. So such damage, even such damage can be prevented. And we can stop the pulpal inflammation if the irritation was timely restricted. It is apparently possible that new odontoblasts can be recruited from the pulpal stem cells, but if the damage is not stopped, it will lead to pulpal inflammation and causing the pulpal exposure. So now coming on to pulp reaction to the restorative materials. So here we have the two patterns, the direct effect and the indirect effect. Evidence shows that indirectly, in some instances, prolonged cytotoxicity and stimulation of hypersensitivity reaction or impairment of host immune responses can be seen. Like say for example, in some components of the resin restoration are released at cytotoxic levels after polymerization is completed. That can lead to chronic stimulation and result into prolonged inflammatory response. And also the resin monomers have shown to decrease the activity of immunocompetent cells in a dose dependent manner. And if we talk about the indirect effects or in the indirect factors, the technique's sensitivity of the certain materials predisposes them to faulty bond to the tooth structure, and that can further lead to dental hypersensitivity, recurrent caries, pulp inflammation and necrosis. Like in case of the etching process, the more mineralized peritubular dentin or as obvious will be dissolved, and this will leave a free collagen fibrils, and when we apply the resin it will form a hybrid layer, or the resin will infiltrate into the exposed collagen, and this hybrid layer bonds between the resin and the dentin. But if the preparation is too dry, there will be collagen collapse and the resin cannot penetrate or cannot permeate into the mesher, and so in that case we have the defective bond, and this will act as a new avenue for the action of the microbes, and this can lead to further micro leakage of the irritants from the bacteria and the irritants from that are released from the as a result of the restorative materials. So indirectly also they can affect the pulp health. The first restorative material that we are going to discuss is zinc phosphate cement, and they can cause severe pulpal damage because of its acidic nature, and they are more toxic when the cement is placed in case of the deeper cavity. So in that case it should not be used alone, and an intervening liner of zinc oxide eugenol or calcium hydroxide is advocated in that case, in the case of the while you use the zinc phosphate cement. Basically the restorations with zinc phosphate base, they showed the more post-op sensitivity because of its acidic nature and increasing pulpal inflammation, because it also lacks the adequate marginal seal, and the pulpal injury is mainly due to the marginal leakage rather than the toxic chemical properties. Next is the polycarboxyl cement. They have the excellent biocompatibility with the pulp, and they are initially acidic, but these products produce minimal irritation to the pulp because of their larger size, because they are macromolecular size. The polyacrylic acid molecules limits its diffusion through the dentinal tubules. They cannot diffuse through the dentinal tubules, thus they are extremely biocompatible and they do not cause us that much irritation to the pulp. Next is the zinc oxide eugenol. The zinc oxide eugenol, it is also acidic in nature, and it provides palliative and obtendant effect in low concentration by inhibiting the prostaglandin secretion, and in higher concentration it chemically irritates the pulp. Small amount of eugenol is released over a period of time. It happens because of the degradation of the surface chelates, and this process is called lixiviation. The next restorative material we have is the glass enamel cement. They have the anti-kerogenic properties, and in case of shallow, medium or even deep cavities, no pulp damage was reported. But the condition here is that there should be no bacterial penetration to the cavity floor. But when they are exposed, when they are contacted to the exposed pulp, severe inflammatory reactions have been observed. Coming on to resin modified glass enamel cement, they causes moderate to intense persistent inflammatory response in the pulp, and they form a large necrotic zone. The toxic reaction here is basically because of the HEMA, that is hydroxyethyl methacrylate, and because of this they have been shown to be more cytotoxic than the conventional GIC. Basically, the incorporation of the HEMA has been proved to increase their toxic effect, and thus they are more cytotoxic. And also, the unreacted resin monomers also can contribute to the their cytotoxic reactions. Coming on to the silicate cements, they are markedly cytotoxic and they show severe pulp reaction. Even in standard depth cavities, they can cause acute inflammatory cell infiltration with the disruption of the odontoblastic layer within 1 or 3 days after the placement. And another thing that is the micro leakage around the silicates may be important factors in inducing the pulpal response. Now coming on to the composite resin. Incomplete polymerization is an inherent property of these resin-based composite, and it predisposes a material to degradation, and there is leaching into the adjacent tissue. So complete polymerization should be tried, or we need to minimize the shrinkage in order to limit the pulpal injury, or in order to stop the pulpal response or further adding irritation to the pulp. But the level of the pulp response to composite resin is intensified, especially in the deep cavity preparation, and in that case when we have incomplete curing of the resin. And this incomplete resin can eventually lead to higher concentration of the residual unpolymerized monomer into the pulp. So this will further lead to the added irritation to the pulpal tissue. Coming on to calcium hydroxide, they induce the tertiary dentin formation, but the major disadvantages is their tendency for disintegration. They are easily degraded into, they are easily disintegrated in the oral fluids, and that may cause a micro leakage at the margins of the final restoration. Otherwise, these calcium hydroxides have seen they generally induces the tertiary dentin formation. Next is the tricalcium silicate. They releases calcium hydroxide during and after setting, and they are non-cytotoxic, and they stimulate the pulpal cell to express biomineralization markers like alkaline phosphatase and dentin protein and transforming growth factor beta 1. Coming on to amalgam, it produces discomfort mainly because of its high thermal conductivity. So a liner or base is necessary to provide the thermal insulation. They are thought to cause mild to moderate inflammation in deep caries, and thus inhibiting the reparative dentin formation because of the damage to the odontoblast. Cast metal. In case of cast metal, the pulpal reaction is basically related with leaching cement used. And pulpal effects are insignificant with the corrosion byproducts released in comparison with the cement constituent or the bacterial product that penetrates into the dental tubules during the cementation process. Pin and pin-retained restoration. So what are the factors that are irritant to the pulp, and what are the various irritating ingredients and characteristics? So let's first discuss about the crack. Suppose if a crack is developed and it connects the cavity preparation wall surface or tooth surface within the pulp chamber, then these cracks will be direct avenues for the irritants for leakage space to the pulp tissue. These cracks are obviously going to act as an avenue for the bacterial products, and they will act as a chemical irritant to the pulp tissue. Now next factor is the vibration. Movement from the slow speed rotary instrument which is used to establish the pin channels, even that will have an effect on the pulp dentin. The third factor here we have the cement. The cement that we are using to lure these pins, are also going to have an effect on the pulp, especially the zinc phosphate and the copper phosphate cement. And these are being acidic are particularly irritating, and they will have a adverse effect on the pulp. The fourth factor is the stress concentration. The stress can occur during function or during insertion of the pin within the tissue. So that stress can be detrimental for the pulp tissues. And the last factor is the conductivity. Thermal and galvanic irritation can be transmitted through the pin to the underlying pulp tissue. So thus, the greater the diameter of the pin, the higher will be the conductivity. As in case of the amalgam we have discussed, the basic irritation comes from this conductivity. So the same is here. The thermal and galvanic irritation can be transmitted to the pin through the underlying pulp via the pin. Now coming on to the pulp reaction to laser procedures. Laser ablation of superficial carious lesion is more conservative than the bulb preparation. But the no predictable advantages has been seen as compared with the traditional method. In case of the carbon dioxide and EAG and erbium YAG lasers, the fusion of the tubules in superficial layers of dentin can be seen. Coming on to the pulp reaction to cavity preparation using air abrasion techniques. So the air abrasion cavity preparation causes some same or fewer pulpal changes like that of the conventional high-speed rotary instrumentation while using a copious water supply. Now coming on to the pulp reaction to bleaching procedures. Using a strong oxidizing agent such as carbamide peroxide and hydrogen peroxide, for 2 weeks it will lead to minor inflammatory changes that is reversible and can be prevented by treating the teeth with fluoride or by correcting the restorative deficiency preoperatively. So these are all the factors that affect the pulp, and we have discussed about all of these things. So thank you.